MTHFR is a real and important enzyme in human metabolism, but common MTHFR mutations have been dramatically overinterpreted, especially in functional medicine. This 30-minute monologue introduces what MTHFR actually does, what the common variants really mean, and how to integrate this information responsibly into a broader, evidence-informed view of health. Welcome back to the Science of Ageless Living. I'm Dr. Ethan Hausman-Marquise, and today we're going to talk about one of the most hyped, most misunderstood topics in functional medicine, the MTHFR gene. If you've spent any time in health forums or had a functional lab panel, you've probably heard something like, you have an MTHFR mutation. Your detox pathways are broken. You need this protocol. For some people, that single phrase has been both a relief and a burden. It offers an explanation, but it can also become a label that generates fear, confusion, and a lifetime subscription to supplements. In this episode, the goal is very simple. Separate biochemical reality from genetic hype. We'll look at what MTHFR actually does in the body, what those famous variants like C677T and APCHOW98C really mean, what the evidence says about risk, how functional medicine sometimes misuses this information, and how to work with MTHFR data in a way that is calm, nuanced, and genuinely helpful. Welcome back to the Science of Ageless Living. I'm Dr. Ethan Hausman-Marquise, and today we're going to talk about one of the most hyped, most misunderstood topics in functional medicine, the MTHFR gene. If you've spent any time in health forums or had a functional lab panel, you've probably heard something like, you have an MTHFR mutation. Your detox pathways are broken. You need this protocol. For some people, this single phrase has been both a relief and a burden. It offers an explanation, but it can also become a label that generates fear, confusion, and a lifetime subscription to supplements. In this episode, the goal is very simple. Separate biochemical reality from genetic hype. We'll look at what MTHFR actually does in the body, what those famous variants like C677T and APCHOW98C really mean, what the evidence says about risk, how functional medicine sometimes misuses this information, and how to work with MTHFR data in a way that is calm, nuanced, and genuinely helpful. Let's start with the origin story. The MTHFR gene codes for an enzyme called methylentetrahydrofolate reductase, which sits inside the folate and methylation pathways, core systems for how we process nutrients, build DNA, and manage homocysteine, an amino acid linked to heart and vascular health. In the 1990s and early 2000s, researchers noticed that certain versions of the MTHFR gene were associated with higher homocysteine levels and potentially higher risk of cardiovascular disease and neural tube defects in babies if folate status was low. As genetic testing became cheaper, these associations caught the attention of integrative and functional practitioners. Later, small studies linked MTHFR variants to depression, anxiety, pregnancy loss, migraine, and more. Fast forward to today, and MTHFR is everywhere. Blogs, TikTok, lab panels, supplement marketing, direct-to-consumer testing made it possible to get your genotype with a saliva sample, and suddenly people saw MTHFR mutation on a report and assumed it was a diagnosis. Social media amplified stories of life-changing results from methylation protocols, often without context or nuance. That's how a complex enzyme in a biochemical pathway became a buzzword and sometimes a source of anxiety. Now, before we talk about mutations and risk, we need a working understanding of the enzyme itself. MTHFR's job is to convert one form of folate, 5-POS10, methylentetrahydrofolate, into another form called 5-methyltetrahydrofolate, often shortened to 5-MTHF. That 5-MTHF is the primary methyl donor used to convert homocysteine back into methionine, which is then used to make SAME, the body's universal methyl donor. So if you imagine methylation as a giant logistics network, tagging DNA, neurotransmitters, and lipids with methyl groups, MTHFR is one of the key suppliers that keeps that network running. Because methylation supports DNA synthesis and repair, epigenetic regulation, neurotransmitter metabolism, and even aspects of detoxification and vascular health, it's tempting to blame MTHFR for almost everything. But that's like blaming a single warehouse in a global supply chain for every delay in every country. It's important, but it's not the only player, and there are backup routes in the system. Let's talk about the so-called mutations. When most people say MTHFR mutation, they're usually referring to one of two common single nucleotide polymorphisms, SNPs, in the MTHFR gene, C677T and A1229AC. A SNP is simply a single letter change in the DNA code that is common in the population. It's not automatically a disease-causing mutation. With C677T, people can be wild type with no copy of the T variant, heterozygous with one copy, homozygous with two copies. The 677T variant makes the MTHFR enzyme more thermolabile, less stable at body temperature, and reduces its activity to some degree, especially in homozygous individuals. A1228C is another variant with a somewhat different biochemical impact that tends to have a modest effect on enzyme activity compared with C677T. Here's the key point. These variants are incredibly common. Depending on the population, up to 30-40% of people can carry at least one copy of C677T, and a substantial percentage carry A1298C. If these were catastrophic mutations that broke detox pathways, the human species would be in serious trouble. True MTHFR deficiency, the severe pediatric onset disorder with very high homocysteine and major neurological problems, is rare and usually caused by different, much more disruptive mutations than the ones we're talking about today. That's not what most people mean when they say, I have MTHFR. They have common polymorphisms that slightly shift enzyme efficiency within a physiologic range, not a broken gene. Now, to the question everyone cares about. What do these variants actually do to health risk? The most consistent, evidence-supported relationship is this. Certain MTHFR genotypes, particularly C677T homozygosity, can be associated with higher homocysteine levels, especially when folate, B12, or other key nutrients are insufficient. Elevated homocysteine, in turn, can increase risk for vascular problems like coronary artery disease and stroke in some contexts, though even here, the story is nuanced. Another clear area is neural tube defects. Before folic acid fortification, low folate intake combined with certain MTHFR variants increased risk of defects like spina bifida in offspring, which is one reason why folate supplementation around conception is so strongly emphasized. Fortification policies and better prenatal care have markedly reduced population risk. Beyond those areas, the evidence becomes murkier. There are studies linking MTHFR variants to depression, anxiety, schizophrenia, autism, migraine, pregnancy loss, infertility, and more. But when you zoom out and look at larger meta-analyses and higher quality data, the effect sizes are often small, inconsistent across populations, and heavily influenced by nutrition and lifestyle. Many early candidate gene studies were underpowered and subject to publication bias, meaning that positive results got published and negative ones didn't. As genetics moved toward genome-wide and polygenic models, it became clear that complex conditions are rarely driven by a single SNP. MTHFR may be one contributor in a larger network, but it's usually not the dominant player. So, where does functional medicine go off the rails? There are a few recurring myths. You have an MTHFR mutation, your detox pathways are broken. MTHFR explains all your symptoms. Everyone with MTHFR must avoid folic acid and take high-dose methylfolate. These statements are oversimplifications. First, MTHFR is not the only route by which the body manages methylation or detoxification. There are multiple redundant and parallel pathways. Second, most carriers of these variants don't have dramatic clinical issues, especially if they have decent nutrition and overall health. Why do these myths persist? One reason is the way genetic reports are presented. Red and yellow boxes, lists of mutations without context, and language that sounds alarming. Another is the protocol culture in parts of functional medicine, standard methylation packages, and one-size-fits-all supplement stacks built around a couple of SNPs. Add financial incentives and compelling testimonials, and it becomes easy to lean into the narrative that this single gene is the master key. The problem is that this can cause real harm. People may end up on high doses of methylfolate, methylcobalamin, and other methyl donors, and develop what some describe as overmethylation symptoms: agitation, anxiety, insomnia, palpitations. At the same time, practitioners and patients may overlook basics like diet quality, sleep, stress, trauma, infections, and environmental exposures because the focus is on fixing a SNP. To use MTHFR intelligently, it has to be placed in context: genes, nutrients, and environment interacting, folate, B12, B6, riboflavin, choline, and adequate protein all modulate how much an MTHFR variant actually matters. A person with a C677T homozygous genotype who eats a folate-rich diet, has good B12 and B6 status, manages stress, and avoids heavy alcohol and smoking may have minimal functional impact from that variant. Another individual with the same genotype, poor diet, chronic inflammation, and certain medications on board, like methotrexate or some antiepileptics, may see more pronounced metabolic consequences. There are also compensatory pathways in one-carbon metabolism. The body can use betaine, TMG, to remethylate homocysteine through a different enzyme called BHMT, and other folate-dependent reactions can buffer changes in MTHFR activity. That is one reason why most people with C677T or A1298C variants are clinically fine and do not develop severe disease. Just as important is what MTHFR cannot explain. Chronic fatigue, brain fog, chronic pain, or mood issues are common and multifactorial. While methylation may play a role in some individuals, focusing solely on MTHFR risks missing more central drivers such as endocrine problems, sleep disorders, gut issues, trauma, or social determinants of health. Genes are part of the story, not the whole book. This brings up a practical question. When does it make sense to test MTHFR at all? Conventional guidelines generally do not recommend routine MTHFR testing for thrombosis risk or general cardiovascular screening because the presence of a variant does not reliably change management compared with simply measuring and addressing homocysteine and other risk factors. Testing is rarely needed in most standard clinical scenarios. A more nuanced functional approach might consider MTHFR genotyping in a few situations. Recurrent pregnancy loss or severe pregnancy complications, especially when homocysteine or folate status is abnormal and other causes have been explored. Strong family history of early cardiovascular disease or stroke combined with elevated homocysteine and suggestive lab patterns. Complex neuropsychiatric or neurologic presentations where other drivers have been addressed, symptoms persist, and methylation pathways are a therapeutic target under supervision. Equally important are the situations where testing adds more noise than signal. Asymptomatic individuals with no clear risk factors doing large SNP panels just to see, using genetic testing instead of basic labs like homocysteine, folate, B12, and a thorough history and physical. The guiding principle is this: test when the result could meaningfully change management, not simply because a test is available. Suppose you already have MTHFR results in hand. How should you think about them? A useful framework has 3 steps. Step 1, genotype. Identify whether you're wild type, heterozygous, or homozygous for C677T and whether A1298C is present. This tells you theoretical enzyme activity ranges, but not actual physiology. Step 2, functional markers. Look at homocysteine, red blood cell folate, B12, maybe methylmalonic acid, and sometimes SAM-SAH ratios in advanced contexts. These markers show how methylation and folate metabolism are performing in real time. Step 3, clinical phenotype. Integrate symptoms, diagnoses, family history, pregnancy outcomes, cardiovascular risk factors, lifestyle, and medication use. From there, patterns emerge. A person with a homozygous C677T variant, elevated homocysteine, low folate intake, and a family history of early heart disease may benefit from targeted nutritional support, lifestyle changes, and closer monitoring. Another person with the same genotype, normal homocysteine, good nutrition, and no concerning history may not need any SNP-specific intervention at all beyond general health optimization. What to avoid is SNP stacking, building elaborate deterministic narratives from panels of minor polymorphisms without anchoring them in labs and lived experience. Genes load the gun, environment and lifestyle usually pull the trigger. Let's talk practically about treatment. The foundation is boring but powerful. A whole food, folate-rich diet, leafy greens, legumes, cruciferous vegetables, citrus, and for some, organ meats like liver, provides natural folate and other methyl donors. Adequate intake of B12, B6, riboflavin, choline, and high-quality protein supports one-carbon metabolism across multiple pathways, reducing or eliminating smoking, moderating alcohol, improving sleep, managing stress, and addressing chronic inflammation and gut health all reduce the metabolic load on methylation pathways. Then, and only then, supplementation can be considered. Methylfolate can be useful, especially for individuals with low folate status and certain genotypes, but doses should start low and be titrated carefully. B12 support methylcobalamin, hydroxycobalamin, or in some cases, adenosylcobalamin may be helpful, particularly if levels are low or borderline. Riboflavin and B6 help MTHFR and related enzymes function efficiently, and betaine, TMG, can provide an alternative methylation route through BHMT. The mantra here is, start low, go slow, and watch the person, not just the SNP. If someone becomes more anxious, wired, or insomniac on a given protocol, that's information. Adjusting doses, changing forms of B12, or emphasizing food-based strategies can often resolve these issues. There are also special populations. Women planning pregnancy need adequate folate and B12, but whether that should always be methylfolate versus folic acid or a blend depends on individual context, existing policies, and clinician judgment. People with kidney disease, autoimmune conditions, or cancer risk may need closer monitoring of homocysteine and methylation-related markers, again as part of a full clinical picture, not in isolation. To make this concrete, imagine 3 brief scenarios. First, an asymptomatic 35-year-old with homozygous C677T discovered on a direct-to-consumer test. Their homocysteine is normal, folate and B12 are solid, they eat well, exercise, and have no major family history. In this case, the best intervention is education and reassurance. This is a common variant. Your current lifestyle appears to be compensating well, and there is no need for aggressive methylation protocols. Second, a woman with recurrent pregnancy loss, heterozygous C677T, elevated homocysteine, and low folate intake. Here, a stepwise plan might include optimizing folate and B vitamin intake, reducing homocysteine, coordinating with her obstetric and hematology teams, and monitoring carefully before and during pregnancy. Third, an anxious patient who comes in on a high-dose methylation stack, large amounts of methylfolate, methylcobalamin, SAME, and TMG, all started after being told they have an MTHFR mutation. They now report insomnia, palpitations, and feeling amped up. In this scenario, deprescribing is as important as prescribing, dialing back methyl donors, simplifying the regimen, addressing lifestyle, and reframing the narrative so they see their genes as a modifiable risk factor, not a life sentence. Language matters. One of the most powerful shifts practitioners can make is to stop calling common SNPs mutations and instead use terms like variants or polymorphisms. Words carry weight. Mutation sounds like something is broken or dangerous, whereas variant signals diversity, not defect. Framing MTHFR as a modifier of capacity, how efficiently a particular pathway runs under certain conditions, allows for nuance. It opens space to talk about how diet, lifestyle, environment, and other genes can compensate for lower enzyme activity. It also reduces fatalism. Patients are no longer broken. They're working with a slightly different setup that responds well to supportive inputs. Practically, this might include simple diagrams of the folate and methylation cycles and myth versus fact handouts, clarifying that having an MTHFR variant does not doom you to disease, that folate fortification has reduced population risk for many neural tube defects, and that functional markers and whole body health matter more than a single SNP. As we wrap up, here are the key take-home messages. MTHFR is an important enzyme sitting at a crossroads of folate metabolism, homocysteine regulation, and methylation, but its common variants are just that, common and usually compatible with normal health, especially in the presence of good nutrition and lifestyle. The evidence for dramatic disease risk from these variants alone is limited and heavily modified by environment and other genes. Functional medicine has the opportunity to lead, not lag, in using genomic information wisely. That means resisting the temptation to reduce complex multifactorial conditions to a single SNP, avoiding fear-based marketing, and focusing on interventions that are safe, evidence-aligned, and tailored to the person in front of you. On the science of ageless living, the aim is always the same: empower you with clear, de-hyped science so you can make informed, grounded decisions about your health. Your genes are not your destiny. They are part of your story, and with the right inputs, food, movement, sleep, connection, purpose, you can write the next chapters in a very different way. If you found this episode helpful, consider sharing it with someone who's been told they have MTHFR. And as always, none of this is personal medical advice. Work with a qualified clinician who understands both the biochemistry and the bigger picture. Until next time, this is Dr. Ethan Hausman Markey, and this has been The Science of Ageless Living.